Mhm. They say God. I hope you don't see it as such a simpleton whereby as the mechanical joint loading because the person is fat, then therefore they are pretty much screwed to get OA, right? That is to let those people feel not as guilty, okay? But at the same time, it allows us a different way to address fat as such, okay? So I think some of you had the same picture as mine. I think we're on the same picture. Yeah, okay. So basically, it's in adipose tissue affecting a hormone called leptin. Leptin is involved in, if I remember correctly, is huh? Oh, for yeah, it makes you feel hunger and you know. So but wait, so then what I think you guys need to know is when a person is a little bit more bigger in size, okay, there is a place to play in your favorite jabs. No, Ozempic. Ozempic. All right. So there are clinical trials that has shown just purely by using Ozempic that they have improved the function of knee OA patients. And it is a class of medications that we are doing if the patient falls under the metabolic things. Alright, so in terms of their presentation, they have a strong metabolic presentation. They have your OA changes with inflammation. Then yes, it is something that's helpful. But Ozempic comes with its own side effect. Once you stop, it pretty much comes back, right? Okay, so this and that's your estrogen. I think someone had this picture as well. I think it's Hui Yue or something. I can't remember who had this particular picture when your answers to me. But just to let you know that it has multi-organ effect, right? It affects on cartilages, so your cartilage don't grow as nicely. You had like I think it's the type 2 collagen formation. Your subchondral bond also has a bit more imbalance in between your osteoblast and osteoclast. Your muscles will not you will not be able to maintain your muscle as well because I think they die a little bit faster. So the cell death is faster, something like that. Then generally will reduce faster. And it is an important part of it whereby can you decrease those things? Yes, you can, right? Because the hormones is just part of it. There are other things that you can use to support the whole system because we recognize OA as a multi-organ problem. Ligaments is another weird one whereby I believe closer to your period, and if you're involved in high change of direction sport, your ACL rupture rate is high in women's soccer. Okay, but I'm like, dude, are you gonna measure everyone's menstrual cycle? And the person said yes. I said, I guess if you're in professional sports, that's what you have to do. If you know that there's a risk of this athlete not being able to play and runs a risk of 18 months off. So, okay, so how I want to see arthritis is what anyone in region should know by now by filling up your homework, the relationship and such. In the past, why I said that is because in the past, we think of them as an isolation. Okay, synovitis means synovitis, then we treat synovitis. Cartilage wear, especially with the X-ray findings, we treat it as a cartilage wear. And think it's only in recent years, but prior to recent years, everything has been driven by looking at the cartilage wearing, resulting in increased pro-inflammatory things that stimulated the whole cascade of problems. So they think start cartilage, progressive injury around there, therefore leading to the rest. So you get a big sort of target of medications or therapy and all that, targeting at stimulating growth of your cartilage. Your stem cell therapy, your PRPs, your blah blah blah, all that, thinking if you change and stop this cascade of problems, it will help with OA changes. Try minimal success rate. Okay? Because they may not be the first person to start. Okay? So the newer projects that people are working on is thinking more towards where the bone start, subchondral bone area. So subchondral bone, when they take a little bit extra stress, they will also cause the process of secretion of pro-inflammatory markers that you guys listed out, or a lot of it. Then your cartilage again has its wear because the base of it is a bit off. Then you have wear, then comes into it. You have your meniscus irritation along it. Then now your synovial fluid is full of this waste product. Okay? And this waste product also further irritates your synovium. Right? Your synovium got synovial sites A and B. So your A is the one that you move, you secrete the follicles, you get your nice beautiful synovial fluid. But you move the synovial site B, you will end up stimulating them and they get thickened and hypertrophy, and they will stimulate a thicker red looking synovial membrane. Then with that, its effect on the periosteum, which is the you see where the sites are osteophytes. So my issue with I asked the team member, and team member says, yeah, because there is osteophyte, therefore there is inflammation. Wrong. The process is the reverse. It's because synovial membrane secretes actually stem cells from synovial membrane, and it promotes the activity around the periosteum, which then led to your osteophytes formation. So osteophytes didn't happen because of inflammation. No, osteophyte didn't cause inflammation, right? But the cascade of problem promoted osteophytes growth. Okay, so hopefully that explains a little bit, and that's where the directions of treatment is going towards. And the whole process here is one multi-organ process where different, our layer 1 to 4 is all affected, right? And that is called knee OA. Okay, clear so far? Quite okay lah. Then I went into trying to answer for you guys what I understand of osteophytes and what you understand of osteophytes. I think when we were covering the spinal one, no, not the spinal one, the tractional heel spurs, the heel spurs and all that. So you gotta understand that there are three main types, but I only know two. Right? I didn't know that the 2 and 3 is similarly linked. So you have 3 main types. The first type is what we have is the traction on tractional spurs of the tendons and ligaments. That's an inflammatory spur, right? So you pull on the insertion side and sympathetic side, then they will lay down more calcium particles. It's not actually a bone growing out, right? It's calcium particle exchange with collagen, so they mix together, so it's a bit grainy. We call those tractional spurs. Sand type feeling, okay? Alright. So those are classic in your ankylospan, so your spine looks like a bamboo and so forth. Those are tractional spurs. But then when I teach you the spine, you start to see bumper head spur. you'd start to see claw type spur. And that's what you see in a joint, right? And in a knee joint, the classic surface will be, so, do you know whose knee is it? This particular shape, look. That is a mouse. That's a lab rat, right? And that took the knee, and there was a very, very small ass kneecap on the top. But that's the area, the stars. Okay, the stars are areas where osteophytes commonly have. Okay, and where does osteophytes occur? Osteophytes occur if you look at. Is there any arrow when I do that? Oh yes, there is. Okay, good. So we go arrow. If you look at this area, that is the cartilage, subchondral bone around this area. So it's around the periosteum area here. And you have to understand what is osteophytes. We start from here, finishing to the final part here. So, fun fact is they induce trauma to the rats and the dogs. Rats, in 2 days, you grow osteophytes. Dogs, in 3 days, you grow osteophytes. Don't know whether it can translate to human or not, because it's very, very rough to get a human to be induced trauma to grow osteophytes, right? But what we know in osteophytes happen is when, remember, the synovial membrane secretes inflammatory and stem cells and all that, they then start stimulating the skin around here, and they start duplicating. The osteoblast starts duplicating around here, right? Then they grow out and growing outwards through here. After that, they reach to a point where you get the osteophyte formation already, but it's not full yet. Then this area here will then start have pores, so bone marrow growing through it. So it becomes whole. It gets filled with blood supplies and all those things. And then your surface cartilage here will grow over it. So then this is also known as osteophyte formation. Okay? We suspect osteophytes is a functional adaptation. We see it in ACL, whereby you cut it, and then the front and back of your tibia will have bubbles, osteophytes. They try to cover more area because you're now moving a little bit more. Suggestive that your body wants to adapt to protect you. But we also have studies that shows removal of the osteophytes increase mobility. But the catcher is, doesn't change in the function and pain. Okay, these are in dogs, right? So, human trials probably they will say removal of that. Definitely, you see what Kumar did. Kumar osteophytes removed and all that. He's got the range. Is he in pain? Still in pain. It's a OA. But what happens to it is, if you imagine the story goes like this. Kumar has got labral tear. As a result, the shoulder starts moving like a bumper shape. So his shoulder, rather than a round one, becomes a flat mushroom one. So it's got a bumper on both sides one. So that's an osteophyte's growth that irritates the movement. So it covers more area as such. Because you got labral tear, right? Tendons around it adapt, so long head bicep adapts to thicken and big and all that. So it becomes like compacted like that. So it's like cannot move. And the surrounding synovial membrane and all that would thicken, hypertrophy and all that. So what we talk about arthritis will occur in any other body part. So far, I'm not saying this is specific to the knee and all that. Okay, so what you learn in the phenotypes, it's not saying this is the knee phenotypes, alright? Though the classification is not that way lah. Any questions so far? Alright. So now, knowing what I've just mentioned, right? If I were to share with you this X-ray again, this looks like a grade 3, alright, on the first grading system that we talked about. But you start to see different things. You start to see, okay, narrow joint space is what we normally talk about, cartilages and all that. But you start to see this blackness here. Okay, that is your subchondral bone, which is now inflamed. Therefore, you take an X-ray, there's fluid, so it becomes dark. Alright, you have bone marrow edema. Okay, so your X-ray starts to see more things. Okay, took some time for me to find an X-ray that points at all these things, so that you can start seeing, hey, there is actually extra osteophytes. So now what did we talk about osteophytes? Osteophytes growth are secondary to first synovial irritation. Therefore, the whole cascade happened. Right? You see, some parts of it hasn't grown out from that. Just now, you remember I gave you a picture where, let me see, here, at this point here, is this one here. It hasn't grown, the bone marrow hasn't grown into the osteophytes, filling up the area that it became part of the bone. Right? So it tells you stories of progressions of these osteophytes. Okay? So you can see in a simple X-ray. Osteophytes is also a progression of the functional adaptations. Right? So what that means to you will be, there will be some form of instability happening in this knee. Agree? Agree. You cannot run. Research says that. Okay? But what I will be going through a bit more now is bone marrow edema. This is what you will see. So on the AB is your X-rays, C is your MRI. So these are two different patients. The top, you see a big surface area of bruising and bone marrow and all that stuff. That will be described in a good MRI radiographer of musculoskeletal specialization. They will write this as they found some subcortical bone marrow edema type thing. Because the treatment for it is slightly different. Are you going to load this tissue? What is edema? Inside is water. You don't have trabecular bone that is full and rich and solid. Okay? Now, what is this one? This we will see in a crack, in impact. So, remember how we talked about this template, right? Well, the knee also has a similar thing. When it cracked through, you have an inflammation that happened around here. So, MRI picked up a high intensity in that goes upwards on. This is a skier that fall down, and then therefore the MRI picked up this one. That they have swelling and inflammation around the tibia, okay, and they have a bit of a subchondral sort of like inflammation around this area here. Can the person wet bear? Huh? Got nothing to do with stability. Yes. So my question is, can this patient, if you see this on your MRI, you prescribe them crutches? Should they walk a lot? No. It's a fracture. If you don't know. Alright? It's a bone pathology, just that it's an inflammation of the bone. This needs some form of rest. So you overload this structure here, they will not get better. Right? So this particular patient, the bottom one, I say walk in the swimming pool. Never come out until I say you can. Yeah. She out of water? No, out of water, she's on crutches. And the part of it is, I take my finger and I do a cock. I do this on the tibial plateau there. It's sharp. It's jumping. This is not your normal pain. Alright? But sometimes if it's too deep inside, you probably need a big cock into it lah. But for me, I just said, look, do that. Imagine it's eggshell, hollow. How is it going to heal? And OA management is specific to the patient that you see. If you see a cortex that's got problem, there are things that you can do nowadays. Okay, so I think only one person came up with the pharmaceutical management of it. Then I just go, look, no, not her, not her. Ben, not surprised again, right? So it's true. I read through all of it, and I was just like, yep. But no, the ones that I'll be introducing to you are what is the current line of management. I don't need to give you and share with you every single thing a rheumatologist has in their armory to help you. But if you want the information, it's very bad, right? But you will see a lot of drug names. That's all. Okay. But here I am trying to introduce you to calcium biphosphate or phosphonate. So very simple. The person goes under, and then they take a material that is called chew. So in chew is liquid form, but they break through your cortex and then inject into it, just like a silicon gel, like, and filler. This literally is known as a osteogenesis filler. This technology is usually not done in the knee. It's usually done for your teeth. So you know how you're receding on your gums? Therefore, the base of your teeth cannot have a screw to fit on. They then do filler. We call it bone fillers around there. Let it set. Then drill a hole so that there's a screw for the base of your teeth to be fit on. Now they have a bigger version of it.
Yeah, I was about to say we're not.
You will hear it in your patients, but I'm telling you the history of how this particular thing started. So there are people who does this. So the doctor is Chan Kin Yuan, in SJMC. All right, Dr. Chan. He's into all this what's it called? He's all into this cowboy stuff lah. So no, he will look at it. He sees it. And he acknowledges that that part needs a little bit of help. He will then offer you as part of it. Whether insurance covered and all those things, I tak tahu lah. Okay, but I just know that calcium phosphates is one of those, and there are other types that will be injected into the bone to make the bone, usually with a diagnosis of bone marrow edema. Okay, so far things that you guys don't know just yet lah, right? For this one, it's quite fun, quite new. Not new lah, but 2010s, you know. This is very, very small. I probably need to zoom. I don't know how to zoom. Is there anything here that I can zoom? Huh? Exit. Oh shit, now it's here. And then now I zoom. Okay. Very good. Now I don't know how to scroll up. Okay, here. Very good. I need to be able to read yourself. Huh? Full screen for me. Okay, this is gonna take too long. Wait. Here. No, cannot. Okay, so we know just now, as we mentioned, bone forms, bone get killed, right? So osteoblast, osteoclast. Osteoblast builds, B for build, C for cancer. Alright? And there are two different pathways you can intervene on a bone. Right? The ones that we are more familiar with is the ones down here. So we have bisphosphates. If you they inject you with biphosphates, it has been shown to kill the osteoclast. Right? As a result of it, then your bone don't get resolved so easily. So you maintain your bone health. Okay? The second one, I can't recall what is the commercial name, the one that we always jab, Prolia. So it's also known as the new Sumap. It works on, you don't have to know, RANKL, but again, it doesn't kill, but it just inhibits the reuptake of your bone. Okay? Boleh, right? So we then have the ones on top. This one, I'm not sure what are your osteoanabolic agents because it is listed as this, but this is something slightly newer. Okay, Romosozumab Zumab as a form of, it comes in a brand name called Evenity. Okay, Evenity has got two actions. One action causes osteoclast inhibition, just like your Prolia, okay, but also causes osteoblast proliferation, meaning it starts building bones. So it technically is good stuff until they realize the side effect is if you got heart problems, you can die. It's got other actions because it's a hormone, right? But this is a new drugs. Prolia has been around. Prolia is injected every 6 months to make sure that your bone stays strong, okay? But Evenity is injected every month for 12 months. After that, you go into maintenance dosage of Prolia. Okay, so it's quite nice because I have a patient that really fails to build muscles. Okay, really fails to build muscles. One, incurred it from trauma when for the calcium injections. Immediately the bone becomes stronger, take load, less inflammatory circulation through the knee start building. Okay, this one is an elderly prescribed by an orthopedic to go into Evenity. They don't cheap, okay, Evenity for once a month for 12 weeks, 12 months. She is now in 5 to 6, one of it, 5 to 6 dosage into it. The thing that I asked you guys to read out on the varus trust, she has it very significantly because the bone is lost. She cannot put weight onto it. Therefore, she will just shift out, okay, and lock and further compress the area. Now the bones is getting stronger. She can go up the staircase, step 1 foot at a time now, because now your bone can absorb and take stress. So don't think just muscles, my dear friends, because your muscles alone will not be able to support the bone. If you got a bone that's like an eggshell, okay, and it's one thing if you don't get anything out of today, is really that. Is I really want you to understand that there are more to osteoarthritis management than what you guys are currently doing. Questions? Well, I said this one. Evenity, and also Prolia.
Prolia has been given for osteoporosis also.
It is bone, right? It is a management for the bone. So, other non-evidence-based one I can share with you are quite interesting ones. They provide biphosphates, but they found out that it leads to uptake of bone, but that doesn't affect the cartilage, which is nice. Okay, but so the osteophytes get resolved a little bit better with biphosphate, right? But don't recommend it to patient yet because it's very weak trials. Then you have high dose of vitamin D, okay, with and without calcium. These are me saying because those are articles I read. I just don't want to put into it. But high dosage of vitamin D alone led to a reuptake of calcium again. Osteophytes reduce, okay, without the loss of bone density, which is very no, with the loss of bone density. So the bone itself lost trabecular. Huh? So they try vitamin D alone and then see how it helps with you versus the classic vitamin D and calcium supplementation. And they find that, hey, vitamin D is great. It reduces the osteophytes, right? But guess what? It also resorbs the bone more, so therefore the bone becomes more porous. Kind of defeats the purpose. So you need vitamin D and calcium. That's the study that says everyone must have vitamin D and calcium together. But don't know whether vitamin D and calcium together will also promote osteophytes growth or not. Right? So those are the few things we don't know. Bex, you want to stand up and have a drink or not? Because a bit tiring. This part is tiring. We'll in about 10 slides we'll go to practical, I promise you. No. So osteophytes are commonly producing pain after they touch onto pain nociceptive structures, right? So the classic one is osteophyte touching on nerves, osteophyte touching on the synovial capsule, rubbings and all that. That leads to further inflammation, then blah blah blah, and all that. Okay? Correct, because that's the part where if someone were to X-ray and then they found osteophytes, the patient may not be in pain. Right? So osteophytes alone is not pain. Okay, we have to be clear on that. But it does limit its range of motion, as I've mentioned. I'm not sure if rats or dogs are one of them. Alright, so we're gonna go into, this will be the last part that we talk. Theory. Yay! Okay? We finished this one, I know. Is meniscus. This is a meniscus. This is a meniscus. So how? So you have very tougher molecular structures, webbing type thing out here. This is the cut through it's a front. Sorry, it's a frontal plane. Yeah, it's a frontal plane. Just cut it through. I burped from the thing. Jesus, girl. Okay, but there are a few things in this schematic that I want you to understand. Okay, because this is a drawing, it's not real, but it's trying to show you when people cut it, looking it through the lenses of microscopes, this is what they see. So then you have a mesh, which is a very thin layer, but then you have circumferential layer that runs like a loop from one end, anterior to posterior, like a loop. Okay. Now, interestingly, there is the synovial capsule that weaves in between, in the middle there. You notice this part here? Yeah, down here. Alright? Okay. You see this part? So, when the meniscus is affected, you will also have some of these structures because you cannot separate the meniscus from the synovial capsule. Okay? That's all I want to say with you. How they are connected from here, in middle, and down here as well. Okay? Wait, which one? Got a picture that looks better? Or they cut it? Oh, I forgot that part. Yeah. Wow. Okay, can you send to the group? I got the article here, so I'll go back to the article. Okay, so I don't know whether you need to imagine it or not. So, what does it mean? When you look at this, you just see different areas that can lead to stresses. There are different areas that can tear because of the organization the way it is. Alright? Let's go with, what's the next slide? I can't recall already. Okay, what does it do? Okay, it basically is a very thick fibrous cup that holds the shape of your femur condyle. Agree? Okay, so where your femur condyle goes, the cup follows. Right? Femur condyle has to glide anteriorly, posteriorly, relative to it. Now, where the femur condyle becomes round, it has to go towards it. Boleh? Okay. The second is we know that because it's a cup, it provides some form of like a hoop type pressure alongside with your synovial membrane as stability. So it is also known as a secondary stabilizer after your ACL. Alright? So that's why after ACL, can we stiffen up the knee? Can. We can still strengthen the knee joint. As a result, we're getting what we have. It is rich in proprioceptive feedback. So therefore, when you train the meniscus, you have to think of joint sets. Okay, ability to rock onto the joint, ability to put stress onto it. Not enough. I think there's another picture that you guys need to know. This is also known as the hoop stress. So when anyone put pressure onto female condyle onto it, the thing will out, right? But because it is holding firm on the anterior and posterior horn, and then there's the circumferential like synovial membrane that's holding it, it holds its shape. It will matter more when it has a tear, but we'll talk about that later on. Now, when you are bending the knee, I think we had it in morning coffee one time. We talk about meniscus movement. All you have to remember, all I care for you to remember is 2 points. It follows the female condyle. 2 is there is more translation in the lateral compartment as compared to the medial compartment. It's fact. Right? Any questions? It's more translation in the lateral compartment than the medial compartment because the size of the shape is different. Right? So then it's a bit bigger, a bit more translation. And that then pretty much is what you have to recall for this picture here. How can stress occur? So we down, it goes out. Oh, it's holding in this hoop stress because you got that circumferential thing. Remember? Just now I told you the middle fibers of the meniscus is the way it is. Great. So now if one of the circumferential is on the peripheral radial zone there, yeah, it's true. You put it down, but there's other circumferential that is holding its shape. Meniscus don't move. Right? So you will still be able to recover. Now I'm sharing with you because I think it's doing meniscus a disservice because I think in uni we were told that 1/3 has got blood supply, 2/3 have blood supply. I think everyone can memorize that. But that's not fair. It doesn't tell you why is some people more problematic versus some people is less problematic. No, it's not yet. What if you can have a radial tear, but then your hook mechanism is lost? It cannot hold. Then you actually have more problematic meniscus as opposed to someone had a radial tear, then the hook meniscus system is in place. That thing will heal versus another thing will never heal. Do you get what I'm trying to say? It's certain tears, the knee can still function like normal again, works well with physio. A bit painful now, but it's okay. But certain knees, once they have a certain condition tear through it, then it starts changing. So now we talk about the hook tear that is causing a little bit of shifting. So then that resulted in the bottom picture here, when it tears through the midline. Not yet. It tears through the midline, straight cut through, okay? Then you expose the bottom. Then if it's exposing the bottom, that's like your bucket handle, the horn beak, whatever, all those that's exposing what is underneath there, that's your cartilage already. Boom, straight on the cartilage because the hook mechanism is not holding on. They cannot go like that, but it will just move away from it to let your bone sit into a new spot, which is your cartilage. Okay? That is the... No. It's a concept. It's a concept that when we look at the meniscus, technically meniscus structure got some circumferential that runs from anterior in a half round to the posterior and it's anchored down. So when you got something like that and you put pressure in the middle, it will just pressure it out sideways. But it doesn't, it still holds the shape. It still holds.
That's IVDs.
It's not quite like IVDs because IVDs in the center is a liquid mechanism. But here it's like circle, but in the middle got a weave through. Whereas IVD got like this crisscross action that restrain a bit more shearing. Whereas this one is more this pressure. There's a spread out like that. It's not water in the middle. It's there's nothing in the middle. Yeah, it's it's either relying on those fibers or it'll be onto the cartilage. Okay, another way that I described to you all before, you can have pressure like that, the hoop tear, so you tear through, okay, or because the shearing is high, your bottom is pinned down onto the tibia, your roots are pinned down, but your femur is gliding a lot more. In this scenario, will be, say, for example, okay, hip internal rotation. Okay, you are a little bit stiff in your hip internal rotation. That doesn't allow for the hip to move properly. So femur don't move that well anymore. So it's pinned down a certain way, and then your tibia has to compensate by external rotate as a result of it. Then therefore you are creating a little bit more shearing force.
So you're saying now the tibia is stiff, the hip is moving more.
I'm saying the hip is stiff, therefore tibia is moving more as such. But regarding this, there's a difference of pressure. One is going this way, one is going this way. It doesn't have sufficient of that range. Then it creates that sort of horizontal tear. Okay? Now I think it's important to share with you how many types of tear are there, right? So this is a little bit more easier slide to see. You got a flap tear, you got a radial tear. Cannot me? I mean, okay. Okay. No. But whatever we need to know is that sort of there. Don't need surgery. That sort of there. Oh, not bad. No, don't need surgery still, because you now understand how the how the structure and the hoop stress and all that. Okay, now how big one there? Why? You keep tearing. It's like the end of it, so you pin on it, and it will move. It will continue tear, and it will continue to progress. Okay. Bucket handle. It's no brainer. It's a definite tear that needs surgery. Roots. Roots, it's also, if the roots are not holding, there's no hook. Okay, that's it. Because you need both ends to tie it. Right? If one is flaying, later I'll show you. Horizontal tear in this one. So sharing. Huh? Wait, we don't talk about what treatment. We're talking about whether need surgery or not. This one, if you send for surgery, I'll whack you. Alright. This is the most evidence-based that do not touch in surgery. It makes it worse. Okay? Why? Because as we get older, our tissue become less squishy, then they shear more. This is also known as degenerative tear. Up to 70% of them performs better without surgery. And in fact, it will be worse if you go and catch out it.
So shockwave.
Wait. We talk about what to below Yeah, okay, where are we? Vertical tear. The cut through one. Sometimes this one vertical cutting through. It will be a little bit more unstable already. Okay? Vertical. So the one.
The vertical and the horizontal looks the same. One is straight.
So remember just now got at the bottom here got a weave from the middle and all that. So the tear can be on the top surface here only, but you still got the bottom surface that supports it. So not too bad. Alright? But I'm not saying 100% no surgery, but the definitely no surgery one is this one, degenerative tear. 70% will respond very well. Okay? The thing that will not do well with physio is your roots tear, bucket handle tear. Alright? Radial tear and whatever complex tear, they will not a lot of time they'll report radial tear and all those things. They will usually report some form of complex tear because they're not that young anymore. Okay? Then what we know? We know that when the roots are affected, you will see one extrusion happening in your ultrasound finding. Okay? You will also see an increase in, did I mention this in the knee? Increase in lateral tibial translation. Okay? When your medial meniscus posterior root torn. Okay? So you get protrusion, you ultrasound it, you see that protrusion, right? Most of you should know about it by now. Okay? You will also see lateral tibial translation. Does it mean it's rotation and all that? No. It can be, just pure like that, or it might be associated with rotation. Alright? I guess it depends on how it is stuck. This is a root stem. There should be a triangle around this area here. Just like this area, there's a black triangle. So at this part here, there should be a black triangle. At this spot, it is missing. Okay? And that's why we call it, and this is the area that at this particular site we should see a continuity there, but there's a bit of a swelling that we notice around this area here. So then we have a roots repair. So prior to roots repair, at 0 degree knee flexion, you only see a little bit extrusion. Okay, you go through 3 months, it's also a little bit here. Okay, now in knee flexion, it glides so far back because nothing is anchoring around this area here. So it moves out. So you will see in knee flexion. So imagine this point, you try to bring the knee into further knee flexion than 90 degrees. What will happen? They will say behind the knee pinch. No, 90 degrees. This is passive. Passive knee flexion wise, you get 90 degrees. You see the amount of extrusion there in this particular patient. So as a result, they suture this end of it around here. Okay? And then you see, yes, it is still extruding, but the volume of it is within acceptable range now. Right? This hopefully gives you an understanding of what happens in your patient's knee. Can you go into the meniscus and manipulate it and fix it in place? Don't badmouth people. Okay, I can't and my team cannot. If you can, you get out, like scientifically, it is a bit hard to fix it. Okay? Jesus. Okay. So this is the part where I want to stress prognostic factors of meniscus horizontal tear. Do not send them out for surgery. They are also known as degenerative tear. Okay? But they often come though together with posterior horn medial meniscus. Okay? It's just because but still try. Now, when you are a bit more kembang, alright, you generally have, this is the fun part, a normal person actually has, when you gain weight from a normal person, you have about a 5-fold to observe a change in your meniscus. But when you are already obese, okay, then your meniscus tear is gonna get worse by 10-fold. This is meniscus intra-substance change, meaning to say looking at the cellular activity in your meniscus itself from non-pathological but see changes to pathological. You are very, very high chance that you get a meniscus tear. But this particular article don't say that whether is it the chemical metabolic component of it or whether is it a mechanical loading of it. Alright? But what this article says is, with a workout of 48 months, shows that it is also protective on the cartilage itself. So, just 4 years. Ozempic make it faster, okay? Alright? But what I'm saying here is, this particular study is not really targeted at finding out how to treat it. Because you notice that they look at the substance there, but I'm trying to look into the report to see, did the substance change back after 48 months? I guess it's also hard lah. After 4 years, you get the person back to look at the meniscus again. So probably also a little bit hard, but all we know is the weight loss led to probably MRI change in cartilage thickness. I'm just taking a shot here, but that like what they measure ends up what they remeasure at 4 years. It's very different. So I'm like, anyway. So that's a weak study.
4 years.
No, but they never talk about meniscus. They just talk about that the cartilage is chondroprotective. What is chondroprotective? Maintain the thickness? I don't know. Like, it's that sort of dodgy studies that I just got, okay lah, but just to show you that this study look at if you gain weight, then they started well looking at meat substance. Whoa, I was reading it. Then I was like, why read front and back is different story, right? So I hate that sort of storybooks. No, I don't read a lot of storybooks. That's a lunch topic. Wait, you want to start this? Okay, so we have a Hofstadter concept. Tulasi asked me to present it, but I am not. Okay, I just let you know. No. If you don't know, because that's where.
Not presenting.
If you don't know about the Hofstadter concept, it should be brought up in your induction. And don't know whether there's a video and all that. Because it's an innovative concept of how we see meniscus, how tibia will move, meniscus itself will move, and femur will move, and then how medial compartment can move relative to lateral compartment. Okay, so it's just how we think. But if you don't want to screw up your brain, for the time being, just chill. I don't plan to share it yet. I think that concept, if you really apply it well, it's very, very good, but it's very hard to grasp at the present state. I think she has a drawing that I teach her, but it took me like one-on-one to guide her there. So we would. So now to your favorite part. What I recommend for it is your beautiful shockwave, and I should expect shockwave to be used a lot more after today. In charge. So wait, what do we know about shockwave? I personally believe that it has more of a capsaicin jelly pepper effect. You hit the same nerve fibers that stimulates your pain, then it allows for relaxation to occur.
Who say there's no evidence on shockwave.
For Adam McKean says a lot, there's no evidence. But for whoever you know, that's how he gathers traction. That's how he gathers these sort of people who goes into that direction, right? So it's just a very left-wing person versus a right-wing person. I don't give a shit so long as the patient improves. But I think this is the study that was that one there is looking at from a biologics perspective. So how it affects it, and this one is, I think it's in PhysioTutor's punya snippet that I took out from. Okay, we know it regulates inflammation, but it has to cause inflammation first before it subsides. So it's the controlled inflammation that I've always talked to you guys about. But what we also know is in this, it stimulates the blast, the fibroblast, the osteoblast. So what that means is fibroblast means it's gonna lay down a lot more scar, right? And then bones and all that. So it creates a little bit more activity around those tissues. And fibroblast means that you can affect onto your meniscus structures, your MCL structures, and now you think MCL, actually you think meniscus as a form of a continuum of your synovium capsule, you will also be thinking along those lines as well. Okay, it's acoustic wave that the new angiogenesis, I am not sure whether I want to induce that or not, but what it means is just blood vessels, new ingrowths of blood vessels to the area. In tendons, it causes pain. In synovial membrane, it causes more swelling and pain. Again, so I'm not sure whether we want to do that, but it is what it is. They say it is a stimulation for proliferation of collagen synthesis. So again, what I try to say to you is, remember how collagen was target of the chondrocytes? Like we try to use that to improve the cartilage and all that. That is, I think, the direction that I attended the conference. It seems to be swaying away from that. We're looking less at the intervention targeted towards the cartilage, but more towards the bone. So Evenity, Prolia, and all those, that stops and gets the bone a little bit more stronger, that in turn make a healthy environment for the knee joint. Okay? 3 more pages. Do shortwave. Alright, this, huh? What? I said 10 pages, 10 pages, 10 pages. The other one you guys know what very well one. Okay, PRPs, right? So PRP is also the same, but we think that it works on improving the proliferation of your cartilage again. I don't think it works on the subchondral bone inflammation because I don't think it can get there. And synovium definitely has an effect on it, yes.
Is it still 50-50? Like, we know that PRP either work, it don't work.
So the most recent thing that we're looking into is whether are we taking the top part, which is the majority part, which is leukocyte rich PRP, versus the bottom part or the middle part. And the bottom part is red blood cell, right? So the middle part, which is leukocyte poor. Okay. So there's a big debate on what do you use, and I'm not sure what Rajesh uses. Okay. I'm just saying that this is 2022 type area whereby leukocyte rich will then stimulate a strong inflammatory response, okay, which then likely to push for a little bit more tissue healing, okay. And leukocyte poor, which is the one that we take in the middle, which is the one that a lot of people has been using, which is just a tiny bit only, where they control for inflammation. So it is a lesser pain flare up, but more growth stimulation. That's as far as I can tell you, because it is still hit and miss, but it is something. What does it change? It changes the environment within the synovium, right? So like I said, if the cascade follows from the bone, then PRP will not work, right? If the cascade started at the cartilage, which it claims it's got some form of effect on the cartilage and all that, it may work, right? If the reaction is to try to work on the synovium itself, the fluid itself, it can potentially work. But then that's where whether you want it to stir out inflammation so that it further settles down, or whether you want it to settle down, actually don't even stir it out and just get the growth hormones to the area. But this area, I guess there's money involved, so they're always trying to prove that it works. So when you read into it, it is very hard to say. Okay? Another one that is exciting, which I will share with you all, is called exosomes. So exosomes is basically a very new thing that is in wellness centers that you hear it being given. It can be derived from a lot of different things. The most common one is from stem cells. That's what they claim it is, but it can be derived from a lot of freaking other cells. But what is it? It is, you won't be able to see, right? Oh, you cannot. Oh, my phone very good. But exosome is a communicating cell. Okay, it basically, I don't have a picture. I deleted it, but it basically is a round thing. It's a round thing. Okay, that our cells will then generate this to communicate with the neighbors, right? So our cell would then say, I need you to tell neighbor to create a bit more things. So then they plug in different peptides and all those things on these communicating cells. And then they'll go out of the cellular body and then they spread and talk to the neighbors. Okay? So the good thing about it is it can be artificially manipulated. So lots of time, this has been pushed as a bigger or better thing than stem cell because it's a communicating cell. It's not quite a cell, so it can pass through the blood-brain barrier with effects of potentially, that's the wellness center selling stuff. Okay, what it can also do is obviously it can communicate with the other cells to say, "You guys don't get so inflamed." Right? That's the anti-inflammatory side that we generally get to see. Right? I tend to see my patients with pain and all that. They are on exosomes. So I'll give you, I have 3 to 4 patients on exosomes already. Okay, they are per needs basis. They are IV drip through your body and all that, and they go by cells again. They'll be like, I give you X amount of cells, how many cells, and you buy a package, whatever. So okay, posterior root medial meniscus repair, but certain parts of the cartilage has a bit of wear, so this person has poor tolerance on single leg hop. We progress the strength, we progress everything right equals left. But when you ask her to jump, just don't feel comfortable. Just don't feel comfortable. So she tried PRPs, didn't work. Okay, and then she go and try exosomes, which then she find, hey, she came in to me and she showed me some of the moves. We did lunges, hops and all that. She was able to do it. So she repeated a few courses of it. I think 3 or 4. I'm not sure the real exact number now. And that's the journey that it started me to look into this therapy called exosomes. Basically, it's a communicating cells that can artificially be generated, and we're thinking that we can then plug in different instructions, I guess, to the neighboring cells. Like coding, yes, it's a pretty fun stuff, and it can be stored very easily, and it doesn't have the ethical issue where the stem cell comes from. Alright, so some new, fresh stuff. Done, have a rest. I did not share. Get retraining. Okay, so we're just going to talk about walking. There's a reason why I asked you about the varus thrust and valgus thrust. Most of you should pick out that the varus thrust occurs when you start loading response. Okay, so if you don't know how it looks like, I am praying that it works. I know. We still want to go down that conversation. Okay, but how? You're gonna get off my screen again, is it? Okay, we pause. Then it's here. Cannot play to there. Cannot. You went into this stupid shit. Okay, this will be your classic patients. Okay. Okay. No, this is he's got, and this is your classic knee OA patient that is going into medial thrust. This is your so-called knock knee presentation. Okay, knock knee presentation is which compartment that is being compressed? Lateral compartment. Okay, So then you have certain instability and all that. You guys like to write a lot of these ligaments and all those things. Actually, I asked for very simple stuff only. Because to me, all the things that you have mentioned are all correct. Because they are all affected in different patients. Okay? Just that you just need to know when you do this, it starts. So this is a medial thrust. Medial thrust starts where? Let's look at it again. Does it play? Does it repeat? We start from here. It works somewhat normal. You cannot see which one. And then at which point, remember, most of you wrote it, at which point does it start to have through? Mid stance to terminal stance. Okay? Alright? So, and that is also where, when you are seeing these patients, you have to start thinking, when do you start your rehab? Do you start your rehab in loading response, mid stance, heel off, or toe off, or swing? Please don't say swing. Right? Okay? Alright, so that is your medial thrust. And then we have our, where is my other one? Lateral thrust. Please drink more milk. No, yeah, it's not farm fresh. So no, don't drink.
So I have a more.
Okay, what is this? This is what muscle activity? Oh, okay, I didn't know it was that short. But basically, you saw the lateral thrust. This one is quite nice. This one has got longer strides. Okay. All right. So now comes the part where I pick up certain parts of the gait that I think it's important for us to focus on and in our rehab. So for the next part, it's all going through different planes of motions. So the first plane of motion is your sagittal plane. Okay. We go into a very unique point of ankle movements. So if you look at the path, so if I'm not wrong, yeah, so that is your loading response, terminal stance, and initial swing. Okay, this one is dorsiflexion, this one is plantar flexion. And what I want you to see is this to here. Did you see that it's an extreme? There's an extreme of full maximum dorsiflexion and achieving the maximum plantar flexion of a person's foot at that point. Yeah, so all of a sudden you go into a big ass extreme here to here. And this is depicted in this particular picture here. So we go into the extreme of maximal dorsiflexion, which is roughly about 10 degrees. And then we go into initial swing, which we go into maximal plantar flexion. What mechanism is involved there is Joseph interview questions. Windless mechanism. So it requires a lot of the end range subtalar dorsiflexion and eversion at that point, right? So a lot of time, what I'll see my patients do is they avoided that range already. They are already in point. The heel has lifted out and they're not actually achieving what I would call the sticky heel. The heel then don't stay long enough for the hip to travel to big toe. right? Heel don't stick on the ground long enough for hip to travel to big toe. Okay, they travel before it, their knee breaks into knee flexion. Okay, Ken? That's one point of rehab. Second point of rehab is you will then need your subtalar to go into plantar flexion and supination for the achievement of the windlass mechanism. The rest of the windlass mechanism I'm not going to talk about, but that also means the calcaneal or the subtalar joint has to go from eversion into full supination so that it can lock down, so that your big toe can provide a propelling action. If you don't, you then cannot control the ankle, you then don't have a stable big toe, then you will be using other things to bring your leg forward, usually right fem. Okay, we talk about it this morning from big toe. This is sagittal plane anchor points for gait retraining tick boxes. Okay, sticky heel, windlass. Boleh? Okay, because I just want points so that when you see it in that particular leaflet that you receive or a paper that you receive, when you say gait retraining, I want you to check box, tick, sticky heels, tick, windlass. Alright? Second part, and look, it took me a long time to break down the whole freaking gait cycle to say which one I want you to focus on. It's like zoom, narrow down like FMS. And yeah, very hard to think. But then the other part that I want you to see is now the knee component, which is where this boy will also have a problem. You always have a lot of problems, huh? Okay. We want to share with you, as we are going through loading response, we go into flexion. Okay? Then, as we are going into mid stance, we are still in flexion but not fully locked out. As we go into mid stance as near extension, then we go into terminal stance here. We then should be somewhere, where are we? We're going into extension, so our leg should be somewhere here. But I bring your attention to this part, to this part. What that means is knee go into slight flexion on loading response, then go into extension as you travel into mid stance, and in terminal stance it starts bending again. What does that mean? Correct. What does patient do? Stay in extension, break themselves in extension, and rock themselves across in extension, in fact hyperextension, on the varus thrust. Hyperextension, beyond the line. Once they go beyond the line, then they try to swing it through flexion. It's going to be very chakat. Alright, so there is no extension. You land into loading response with slight flexion. Okay, then it goes into extension. That's your posterior chain activation. That is your hamstring that's doing no pulling you to walk forward. You're not using your quads to push you forward. At this point, the hamstring is doing a curling action into extension. A curling action into extension. So then this comes down to the second checkpoints of the knee in sagittal plane. You need to look out for loading response. That the knee loads in flexion. What happens when you have loading response problem? The which thrust? Vagus or valgus? Varus. So they then already start in varus thrust weakness into that posterior chain gastro tightness that we discussed in our morning tea or coffee. So then you need to make sure you rehab this loading response in the knee. And then you need to teach them to pull from the knee posteriorly, but not push from the quads to straighten out. Ellie, go up staircase, you use quads or hamstrings? Not wrong. That's what, okay, can. But yeah. Because you go into a little bit more hip flexion, therefore the answer is good. But for walking, you should tell me hamstrings. Okay? Alright, so now I like it. Alright. So this is the knee gait retraining points. Don't say I don't tell. Alright. I don't know how to name them, but I just know that these, if you don't have proprioception, they will lead into your capsular structures. And then therefore you lead to your problem. Okay? We'll go through all this in how I do it in just in front of this mirror later on. Okay? Now we go into this point here. We've got the same windlass that we talked about just now. Right? Okay? But this part will be covered by Shani next month. In the figure of 4. This is transitioning into the figure of 4 already. But I purposely put there, but don't tell.
Like your hot
Yeah, like hot center. No, because you see, if there is 2.2 point, right, it gets a bit odd when I give you 3. Okay, anyway, so then the hips. The hips is actually the boring one, which I don't think there is a strong need for us to read. If you settle the ankle and the knee control like that, your hip, the only thing you will get is this point. The foot, the big toe, and the hip. Remember in the when they travel across, you want the sticky heel, the hip goes there already. This will happen.
Can I just say that the criteria means you need to dorsiflex at 10 degrees?
Wrong. Dorsiflexion at 10 degrees in our objective test, does it equal to gait function of, yeah, correct. So what I'm trying to tell you here is, I don't care the range you got or not. I care about in a day-to-day function in our knee program that Regent is going to do for every knee patient. You need to make sure that you tick these boxes. Alright, so the knee program is now so-called simplified to a standardized area where it contains a lot of the essence that I teach you all, but everyone must follow. You need to show me that you have done this education to the patient, sticky heels, windlass mechanism. So we all know in this group here, we all know what you're talking about. Alright? Cool. Now we say the hip is relevant in frontal plane. This is a pronation and supination. So that's a frontal plane. I kept it there, but I decided not to talk about it. Because if you are able to get sufficient ankle control just now, you will. However, there's a catch. A frontal plane gets affected when you need to prescribe orthotics. In some people where there are bone collapse in the joint already, arthritic joint that cannot achieve that amount of dorsiflexion, or you want them to get the knee better faster, but sacrifice some ankle control, that's where your orthotics comes in. Right? So, if in the frontal plane, a person land in laterally, so they are landing here in supination. But the trouble with the ankle is they supinated for a long time. Until it reached the forefoot, it collapsed down. So then it's not this picture already, right? It stays on the outside foot. Then your orthotics needs to put there to tilt them into calcaneal eversion. You're trying to tilt it so that it goes in, right? Eversion. So you want to roll it in. So this is supinated foot. The vice versa can also mean the person land into eversion, but very quickly, rather than take a nice sweet time to reach into maximum eversion, it hits maximum eversion here. Then you need orthotic support in mid-foot navic area to push the eversion profile to go there. Faham? Very simple, ma. Right? Okay. But the person go onto the toes already, but don't have enough windlass mechanism because the ankle is shit. Get the heel cup shoes with a big toe thing that can move. Then all this covered. Boleh? But frontal plane we don't talk about it. Yes.
Going up is not pronation.
Huh? Yeah, pronation. You're going up into pronation. Oh, in inversion, eversion. In evert. Right? So that's how I think of. But that's where your consideration of orthotics happen. Okay? I mean, you can rehab the foot up, but not the topic of today. The topic of today is in your gait retraining. You can then start considering which part of the hip that you want to look up for in the frontal plane. The thing that I will get you guys to make sure is that good? Huh? Macam tak ah? Okay, is that Trendelenburg sign?
No.
Wrong, that's called normal. Okay, so when does this particular thing occur? Huh? No, but before that, before swing? Pre-swing, and then before pre-swing, toe off is like this, off ma. We call it terminal stance or like, you know. So at that point there, it's where you have a 5-degree tilt or hip adduction close chain. So it doesn't mean I am moving this hip there in adduction. I'm moving the pelvis there. Alright, so you have to keep that in mind when you're rehabbing. I don't want to see adduction strengthen my adductors. I tell you. It's not here. The adduction has to learn from the pelvis. So if you think a simpleton hip adduction exercise, people squeeze knee down onto the floor in an adducted manner, is it gonna help with the gait function? Not quite, because the function is pelvic to the hip close chain. That's why side step down. You better not do it. That's why in your knee program, step up, step down, I force you guys to start with the first movement, side step down. Okay? So any patients when they're walking, you want to get the first thing. Now after that, when you mid stance, okay, the pelvis is level already. If in mid stance there is a pelvic adduction, it is a Trendelenburg. This is not Trendelenburg. Faham? Did I say Tiao Gao Yu for this component? It's only the adduction one lah.
No, copy your sentence. You tell me this.
Okay. Yeah. I wish he has a boy. Then, then the boy would copy back to him. Oh, then he knows how it feels. Oh, for sure. Okay, the second part. So this is frontal plane. So frontal plane, the second part you need to look out for is the ASIS. It's easier to look out for, okay, because when you say the hip joint, people don't know one, alright? But officially, most of the time, the hip joint is a little bit more in the center of gravity relative to the foot. But in a walking phase, you need to pivot over your hip joint. You need to pivot over your hip joint. But what if majority of patients don't pivot into the hip joint, they pivot into their lateral musculature and onto their pelvis? This is what you see in most of your patients. And they end up shearing their lumbar spine. You treat the pelvis problem, but you never teach them how to walk into their hip joint. How would that work?
Good question.
Okay. So in this scenario, I often want my patient to feel something in the middle here when they feel it, when they're stepping through, but I don't want them to feel on the outside here when they're stepping through. My rehab on this one is not in the frontal plane, but it's only to show them that when they're standing, I hold their hip and only give them a tiny bit give this way of 3 to 4 centimeters side shift only. I mean, if a person's waist is a bit wider, the hip is a bit longer, give them a little bit of a space to move lah, okay? 6 to 7 or 8 centimeters I have given in some people this size.
They are already going to the lateral already.
Yes, and it's normal to go lateral. If you look at this dot, it goes lateral. I don't touch screen. they go lateral. I'm forgetting things nowadays, you know. I left my coffee cup in Sheyi's room, and then I talked to her, and then I went out to the gym and go out. I cannot find it for a long time. I was just like, so yeah, it's okay. Don't think too much when you're doing work. But anyway, so there is supposed to be a translation. It goes like this, okay? But you won't be able to feel this, but you'll be able to feel at least something translating sideways. But you have to know that you can allow your patient to shift sideways a little bit if they are male. A bit more if they are female. But not too much more, whereby they end up, alright? The U becomes a big smile, then wrong. Okay? I don't know. Different people waste different gift lah. But you cannot expect a lady with a waist like this and the hip sits away here and they need to not shift at all, like 3 centimeters across like that. They're still not in the middle. They're still not putting their center of mass over to the foot. Yeah.
Look very bad, very obvious.
But it's okay. So long as you're putting weight through the hip joint, but not through the lateral musculature. She used to, she ended up a lot of that, and that changed.
I had a patient back then when it comes in, she has hip dysplasia. So whenever she goes to that stance, she'll clunk.
Wrong. Where is the clunk from? Is it on a frontal plane?
I see her from a frontal plane. She'll clunk.
That's what we're going to ask. What's the next plane that we're missing? We haven't talked about. Transverse. Okay. Transverse, if you know that hip adduction occurs close chain, pelvic to there, same concept. So I had to find another picture to help you guys understand this a little bit better. Where is it? So if the foot is planted, if you think pelvis head down, yeah, good. If you think the pelvis is scapular, scapular going forward is protraction, scapular going backwards is retraction. That is a biomechanical terminology for wings looking structure. So in ileum, we also in biomechanical studies will describe it as protraction and retraction of pelvis. Nutation is relative to sacrum on ileum. It's a specific terminology. I'm talking about ileum in biomechanical study. They like to create their own terminology. What can I do? No. This is open and out, but just think. This one go forward, protract, retract. That's it. Because they are very like planar type thinking. So in transverse plane, you describe protraction and retraction of ileum. So now we are standing on our right hip. You stand on right hip. Your pelvis is retracted on the opposite side. Retracted. Okay? Retracted on the opposite side. Your hip is in what rotation? Good answer.
The right hip.
Yeah, it's got the right hip is in external rotation. Very good. Okay, so now when the left hip goes forward, your right hip is in internal rotation. Simple enough, lor, because that's like the hip adduction thing, right? Okay, now we goes into when does your hip go into external rotation versus internal rotation. Your hip goes into starting of external rotation after it passes behind you into terminal stance. And it stays externally rotated in swing phase, going down into heel strike. Upon heel strike, your hip starts internal rotated during swing, protract, retract. Yeah, so not written here, but this video is saying it. Yeah. So upon heel strike, it starts going into hip internal rotation. Okay. This is where I rehab my patients a lot in my hip dysplasia group. Tunku Jahil. Tunku Jahil has to do a lot of extension, external rotation, extension, external rotation, flexion into that ballet position, flexion, so that she swing her leg through, she don't internal rotate her leg through using TFL and all that shit. Okay, she has to external, so as deep rotators, stabilizing, controlling that swing phase. Okay, upon heel strike, then I force her to learn internal rotation. So she has a lot of glute med, control, rocking through her butt, you burn, whatever, all that. Everything I use the word ballet. Right? So lots of hip control. By everything I'm controlling her hip, not too far to the side. I roughly know what she can do. Okay? But she's now able to control that very well. As a result of it, her medial thrust is almost minimal. When she stacked it well, who was with me? When she stacked it correctly with the hip. You guys write a lot of glute med weakness and all those things, right? Don't think just glute med. Think movement and then rehab that movement. You will find that with all this terminology, she can stack, she can walk on that hip. Previously, she was stand on it. She said, whoa, I don't dare to stand on it. Because she's suffering from a little bit of medial thrust. She's feeling a lot of lax tension around the front, anterior capsule, collapse, obviously, the lateral joint or lateral compartment. That's what you get. Okay? So I'm not saying that's a treatment for you, but because you understand gait now, that you can then retrain stance phase, every single stance phase, for heel strike, all the way to close to terminal stance. It is all in stance phase or internal rotation. And starting terminal stance, your hip needs to start open up into external rotation. Bend the knee, but your hip stays externally rotated. Else you will use TFL. You externally rotated, bring that knee forward. Otherwise, you see the knee goes out, goes into adduction, sartorius, engage, extend the knee, step through. Pes ends kena. Alright? So you need to get it external first. If that part external is not done, they will initiate TFL. The next friend next to TFL, sartorius, the external rotate, hook the foot, step into it, and then she starts getting pain right here, left hip. Yeah lah, but I realized that releasing for her is not as effective as training her first, then give her a spa later. Because no, she is for most of the time. But yeah, so sometimes this is motor control problem. And you try to release them first. Yes, they feel pain here and all that, right? But if I release them, that's the structure, then she starts getting more pain. She feels more stiff. She feels she cannot control that range. And that becomes more problematic. But every patient loves a release. So, has to give her the release for those areas that's problematic. Okay, so now most of the time she shut up when I do what I need to do. Right? But I'll just say, yep, you got this now, I got this now. But there's something that I cannot go over, which is plyometrics. When I start loading plyometrics, her knee within 2 sessions will flare out. So, meaning the cortex of the bone not very strong anymore. So, never mind.
Why not you do
Cannot. We try to do bounce. We try to do.
you did the trampoline?
Cannot. Cannot. I mean, she can trampoline and then flare up. Then I load the tendon to get it stronger, and then go back to trampoline, still flare up. The one it's okay lah. You don't need to run.
Have you tried trampoline on the
Trampoline on the reformer. The thing about it is I'm also facing sarcopenia. Right? So if I don't load her enough, Pilates is not gonna touch the muscle mass maintenance. So really cannot. Evidence says cannot. Pilates builds tendon, tensile, and fascial tensile and all that. But in terms of load, right, you cannot quite get the muscle growth or muscle maintenance response. Because if you're some parts of Pilates can, but the reformer type cannot because your body weight is not on it. You know. I mean, if a patient is already so bed bound, it might have some positive benefit. But if a person is weight bearing type patient, that full rep spin is not going to mimic anything.
So then chair
Something that she has to weight bear. Yeah. So I stand next to the chair. We're working on the leg pressing down, but she's actually balancing on that standing leg. Lots of things like that she has to do. Standing on the reformer, the issue with it is it's super high, right? So I tried it. I climbed a pool out before and all that, but the coming down part, she don't have enough control. The loading into the end range knee bending, I end up meniscus tear. Degenerative meniscus. So the behind the knee, they start getting the pictures that you guys saw, those extrusion type stuff. Yeah, you go and palpate behind the knee there. Damn sharp, damn painful. She put weight onto it. She cannot fully bend it. I put blocks. I put hold on, and then she goes sideways to come down. She cannot have enough knee bending range and all that. Anyway, so all done. Any other questions? Are we familiar with the gait retraining that we need to do? Because the knee project team needs to present to you their stuff. With the checklist should be okay. Great.